telehealth and the opioid crisis. Specific to telehealth, we've had an MAT clinic and telehealth psychiatry. With MAT, specifically buprenorphine, we provide maintenance appointments via telehealth. And we've had psychiatry available via telehealth for a few years now. Exciting things that are happening currently as we work in 2 acute care settings, providing SBIRT, screening and referral to treatment, consultation, transportation for those patients who say yes to treatment. And as we work on a couple of projects to provide telehealth treatment, one through our opioid grant, which I'll get into a little bit later, what we're doing with telehealth for that opioid grant to provide treatment and service access to 65 counties in Western Kansas. We're also partnering with KU, Wichita State, KDH&E on a HRSA grant to provide telehealth assessment and telehealth treatment for pregnant and postpartum women who have high-risk substance use. And in Western Kansas, I've applied for a grant to provide similar resources that we'd have a peer mentor embedded within a hospital and clinic setting to assist with the screening process. And we would have a counselor designated to provide telehealth assessment and also telehealth treatment groups within a clinic in that hospital in Western Kansas. And that's through SAMHSA. I'm waiting to hear back and see if we are receiving that grant. So there's just a lot that we're doing with telehealth. Really, the focus with telehealth is to create access and capacity to serve patient needs. I think largely when you talk about rural and frontier Kansas, for sure, we've left out a group of the population and patients that are in need of services. And there are a lot of people who need services. Many more people than we're seeing actually accessing treatment services might be in need of services, and I'll review some of that data. So I always have to start my presentations talking about addiction. I just think it's important to keep reviewing addiction as a disease and what that process is for the average addicted brain versus the average non-addicted brain, and what that means. Because as we can look at each other and we all accept that we look different, oh yeah, of course people look different. We're all different. We're all individuals. We almost expect all of our brains to function exactly the same, which isn't a correct or accurate way to look at anything. You know, each person inside and outside, we differ greatly from each other. So the brain process, and largely focused in the reward center of the brain, is functioning differently. And, you know, in a person who is diagnosed with an addiction versus one who's not. So to say that, well, you should just stop using that substance, I can have a beer and stop, or I can abstain completely, or why are you using an illegal drug? You know, that's so bad for you and there might be legal consequences. We're not really understanding that basic level of what the disease of addiction is, how it affects us biologically, that process, that biological process in the brain, and then the retraining as it, you know, we think about thoughts and emotions, and we're all dynamic individuals, and making changes in our lives is very difficult at a very basic level, not to mention when you get into someone who's diagnosed with addiction and you start talking about the addicted brain and retraining that process. So just to give you a little bit of an idea there, I mean, at a basic level, if anyone's ever tried to change a behavior, if you said, I'm going to eat salads every day for the next month or the next year or for the rest of my life, or I'm going to start running more, or I'm going to do this or do that, that's a very hard process. Or there's certain things you do that you're wanting to stop, such as eating out at certain places, or maybe it's something else that you view as, man, I spend too much money each month on purchasing clothes or whatever it is. It's a difficult process, and we're able to give ourselves a break if we don't do all of those things. If you saw a doctor for diabetes and they were giving you medication and also having you adjust your diet and exercise, and you quote unquote relapsed, and that's a statistic where you see relapse rates among people with high blood pressure and diabetes and asthma very similar to those with addiction. We don't think of it that way. But if we go into the doctor and we say, you know, I started eating at McDonald's for lunch again instead of eating salads or whatever it may be, the doctor doesn't say you failed your treatment and you're never going to get better. With addiction, I think that's often the case, that society would view the person as a failure because they're not just stopping. So we need to remember that, along with the process of, we all have a hedonic tone, and hedonic tone is just feeling okay. Throughout the day, we feel okay most of the time. It's not a positive or negative thing. We just feel okay, normal. That's our hedonic tone, and everyone has that. Now, someone with addiction will have a lower hedonic tone. And essentially, one of the components of use would be that when someone uses a certain substance, they perceive that they feel okay. I feel normal. I feel how most people feel all the time. I like that. They can also feel high and, you know, go much higher than that hedonic tone. But over time, as the hedonic tone is increasing and increasing because drug use is common and the person's using often, regularly, that gets very high. And when they stop using completely, their hedonic tone drops even lower than where it was when they started use. So they feel even worse than they did before they started drug use. And there's this adjustment that happens over months, 6 months to a year, where they're getting their brain readjusted without a substance affecting the process. So we just need to remember all these things with addiction, that it's not as simple as some might perceive, and definitely popular culture doesn't help that belief. So diagnosing addiction, just to go a little bit more information. Addiction is not that someone's physically dependent in and of itself. I know someone who takes allergy medication and they're physically dependent on that. If they don't take the medication in the evening, about 3 o'clock the next day, they feel very ill, just it's withdrawal symptoms because of that medication. And there are plenty of medications that people have tolerance and withdrawal. You see those bold statements at the very bottom of this list. If someone's prescribed a medication, taking it as prescribed, and the only thing present is physical dependence, tolerance, and withdrawal, that's not an addiction. If someone's taking something, and plenty of times, let's talk about opiates specifically, someone's prescribed the medication to have a positive effect on them. And I'm someone who was prescribed opiates after a surgery, and I didn't like how it made me feel. But I was like, man, I feel very horrible without it. I'll use it to get through this pain. I don't like how it makes me feel, but the pain's even worse. So plenty of people have had that experience. So it started with a positive, relationship to that substance. And it may start that way with many other substances. But over time, the negative effects, consequences of use build up, and the positives decrease. And you're seeing all these negatives as you look at the diagnoses for a mild substance use disorder. So it'd be a mild opioid use disorder if 2 to 3 of these were met, a moderate opioid use disorder if 4 to 5, and a severe opioid use disorder if 6 to 7 were met. So it's continued use despite negative consequence. That all these things start adding up, and the use is continuing, and pieces are just falling apart. Losing a job, affecting relationships, getting legal trouble, using when you shouldn't be, so possibly operating a vehicle after you're using, or you're just building that into your daily life. People can't count on you for things. You're thinking about the substance and preparing to use the substance often, spending a lot of time. That just becomes a priority for you. I need to get this. I need to complete that process for myself, and I've got to find where it is. And you're giving up a lot of things as you're going through that process. So just to give you a little bit of an idea how addiction is diagnosed, and what addiction is and what it's not, and the difference between physical dependence, which can be okay if you don't have these other criteria met, versus addiction, which is the negative consequence and continued use, and that's how we diagnose it. So something to mention here as we talk about telehealth and the patients who might need this service. So the data here from 2010, and I saw something recently that's still along these lines, but I think there's some updated data now. 1 in every 10 Americans over the age of 12 could be diagnosed with a substance use disorder. That's quite a few people. Now, only 11% of those with an addiction receive treatment. So as we have this population out there with an untreated chronic disease, how are we addressing that? How are we asking the question? Do we know the resources? And why is this rate so low as far as the number of people accessing treatment resources? I will tell you that one of my theories there is we haven't been doing a good job across the country asking the question. And if someone says yes, knowing the answer to the question. Or if someone says yes and we say, well, there's no treatment facilities or no resources nearby, are we doing something about that lack of a solution when someone says they need help? Are we making it okay by asking those screening questions and working with patients and saying, this is about your whole health? Substance use can affect many different areas. And when I'm treating you and I want to know what your illness is, what your ailment is there substance use present? And am I even treating the right thing to help you get well? So if we're going to ask about diet and exercise and tobacco use and anxiety and depression, are we also asking about their relationship with other substances and how that might be affecting them? We haven't done a great job of that historically, and oftentimes people coming into treatment are being referred through the criminal justice system. So within that process, someone's saying, well, you need to go because here's all these negative consequences. So there's some motivation. I would say primarily you see a lot of people referred by the criminal justice system. You also see self-referrals. You do see medical referrals. We've seen that increase over the last few years, which is great, but it's going to take all of that. And people are going to have to feel safe to even bring up, I I think I have a problem with this. And without fear of being forced to go to treatment for 60 days or losing their job or their family or getting a legal charge or just not knowing what comes next, or if their doctor even knows what to say to them after they bring it up, we need to make it okay by asking the questions and, you know, allowing them to have a safe space to talk about their health in relation to all of their other health needs. So I jumped into this, but how can we do better? We need to ask this question. We need to make it part of our health visits. We need to make it a part of primary care and acute care, and where are people going and where are they talking to people and where can they get more information if they're not already getting it through another referral mechanism to treatment services. So treatment, drug and alcohol treatment, addiction shouldn't be this thing that's separate from, it should be a part of. So when you talk integration, and I know there's a lot of focus on that, which is great, you need to talk about physical health, mental health, drug and alcohol, counseling, addiction, substance use disorder. That's a component of mental health, but we need to pull all these things together and make sure we're being thorough. So understanding the resources, if a patient says yes, what do we do next? And if there's no solution or available resource, where are we going to start talking and planning how we can get a patient services? Medication concurrent with counseling. When we talk about medication-assisted treatment, it's not just taking a medication and that solves the biological component. Humans are dynamic. We all have many different areas. We talk about the 8 dimensions of wellness, but there's other thoughts, there's emotions, there's these other pieces that just aren't going to allow a medication to be a magical fix. Individuals need to learn and grow and change with this process, and that's going to require counseling along with the medication, as you see with other treatments that also might require medication at times. We can talk about diabetes or depression or other things, but drug and alcohol treatment's not different in that aspect. We can't just treat it and fix it with a medication. A treatment team, as we talk about integrated care, we need to all be on the same page. Of course, electronic health records are great. Hopefully over time, as we talk about records communicating with each other and confidentiality laws, HIPAA, et cetera, how can we do a better job of connecting information from one provider to the other? How can we be on the same page and operate as one team? So when a patient walks into any of our facilities, we can know how the patient's doing and how to best operate and provide them the best service, whether it's from us or another team member or another agency. Can we treat the patient effectively and efficiently by operating as a team? Or if you have your own team in-house to provide multiple services, that's great as well. And then innovation. CKF's always been very innovative. CKF was innovative long before I came here. Our past CEO had done a lot to just expand how we focus and provide services. Since I've been here in 2010, and really built programs as we see patients at Salina Regional Hospital, also Stormont Vale and Topeka. We built those systems into those settings, and we considered, you know, what else do we need to do? And as we received the opioid grant to provide services to 65 counties, technology was something we'd been doing a little bit with, but I think there's a lot more we can do even at this point as we're starting to do more. The list goes on. There's a lot that can be done with technology, and we need to follow that process to promote access to patients who might lack access. The telehealth bill in 2018 is a great thing. I'm glad that went through. Some of the barriers there, or one specific barrier, is we cannot bill services if the patient is at home or in a school. And I'll focus in on the at-home part. If I want to create access for a patient who's 2 hours from a treatment center, and then the telehealth bill comes along and say, great, telehealth, we can promote access, we can remove barriers. And they say, well, that doesn't mean you can sign in from home to get this. And they say, well, I'm still 2 hours from a treatment center, where now at the center, they have a professional signing in via telehealth, which helps the center get the staff available. It doesn't help the person who still lives 2 hours away or doesn't have a car or ... fill in the blank. So I think there's a lot more that can be done there. And the other thing is that if people pay out of pocket for a service, they can get a service like this. I think it's called, is it TalkSpace? With, maybe not TalkSpace. There's a commercial with Michael Phelps. He can sign into therapists just from his phone. We have that technology. Zoom can do that. We're doing it now for a telehealth support group in Western Kansas because we have a grant to fund it. But unless you have money to pay out of pocket for a service like that, your insurance isn't paying for it. On the flip side, insurance companies are providing this type of service and they're paying themselves essentially. So Blue Cross Blue Shield, I think Sunflower, I saw something like this. Members can sign in from home to get instant access, but we need to keep pushing on this. We need to provide instant access to individuals who need to come through our agency or another facility that isn't allowed to get reimbursed for that service when a patient signs in from home currently. So integration, just to continue to point out, there are individuals accessing primary and acute care who have substance use disorders, or maybe they have moderate, severe, say high-risk substance use going on. So the data would show that 17% come through acute care would leave with a substance use disorder diagnosis. What I've noticed in some of the acute care settings as we've gone along and assisted people in the process is maybe the SUD diagnosis, substance use disorder, isn't even showing up because they're so focused on the other components that they don't even get it listed. So when you're researching the primary, secondary, tertiary diagnosis, you're not even seeing substance use disorder. You have to dig into the record a little bit further. So we need to do a good job of accurately recording the information and all diagnoses that are going on with the patient. So if you're going to run data and see what kind of need is there for your patient population, you need to accurately be recording that data from the onset. The other component there is in primary care. So 23% of patients coming through primary care would screen positive on the audit C. So the audit C asks some scored questions about alcohol use, and then there's an additional question about drug use. So just to give you an idea, as we started this at Salina Family Healthcare and we were screening in that setting a few years back, they have their own staff now and still have the process intact and refer patients to us. But as we started that process, we saw that that was accurate. You were getting that percentage of positive screens. I think ours was around 24%. So there's individuals going to primary care who need a service, and maybe we're not asking the question. There's individuals who avoid primary care, and they don't want to go talk to anyone because they might get in trouble or they don't have the money or various reasons. They might use acute care as their primary care service. So if they're feeling really bad, they show up at acute care, but that's not the right place for them either. And that's a very high cost service that people need to access for the right reasons. What if the patient actually needs addiction treatment instead? And can we, and we've seen through the hospital setting, refer patients somewhere else and get them the service they need. In the hospital settings, we've seen that when patients say yes to treatment, that they return to the hospital less often. In an official study we did 6 months before their consult and 6 months after, for the patient who said yes during the consult to treatment, we saw a decrease of return visits. And let's see, 69 of the patients had decreased visits, 42 had 0 return visits after saying yes to treatment. And we were able to see some good outcomes there. And we continue to see that. We have 4 years of data, and we see that over time, people who engage in services are returning to the ED less and less, and they're getting the right service. So how do you put these components into practice, and how do we utilize technology and be innovative with the process? The screening and referral, assessment and recommendations is a component to get them the right service and get your authorization. Providing treatment, that could be individual or group treatment. I would say individual treatment is okay for someone who's highly motivated and very insightful. Group treatment is very powerful for an individual who needs some of that insight and lacks it, because they're going to learn from the people around them and see some of themselves in those people, that they'll start identifying things in someone else long before they're going to identify it in themselves. So that group treatment process is really a powerful process for a lot of patients. Medication-assisted treatment is the MAT there, and we'll talk about buprenorphine, Vivitrol, naltrexone. We'll consider some ways that you can utilize technology for those services. And then also care coordination. Of course, I mentioned the treatment team earlier, and we all need to be on the same page in that process. So I'll start with ESPR. ESPR, as I mentioned, we started at a FQHC here in town, and we currently have staff as we built it within Salina Regional and also Stormont Vale. So as patients come in, you're providing that screening process. Now, asking about alcohol use, about drug use, the audit is specific to, well, I mentioned the audit C. The audit C is a universal screen. Nursing staff can ask the audit C, which is, I believe, 3 scored questions and 1 question about drug use. We score the 3 questions about alcohol use, and we review the question about drug use, and if there's any positive answer there, that's a positive screen. The other components of that are if the patient has a positive urine drug screen, if they have a BAC, if medical staff say this patient really needs the service, that's also a positive screen. So we can follow up with the patient. The craft is specific to adolescents, and the questions are more appropriate to that population. Opioid risk tool is a component that can be used as well. We're not using this in the settings that we've built the process in. However, I've assisted a setting to use this as essentially their startup screen. It gets used often in pain management clinics to understand if there's risk of providing this patient with opiates. But there was a setting that just wanted to use this in general. And then if the patient says yes to some of these questions, they would go into a full screen. So as I mentioned, the 3 questions about alcohol use and the 1 question about drug use, that's a universal screen. If they say yes to any of those, or if the score is high enough, then our staff would come in and provide a full screen. So the full audit, the full DAST, the full craft. There are more questions that need to be asked. I think it ranges from about 10 to 15 questions that our staff would sit down and ask the patient and just review even further what's going on. There may be some false positives. That's okay. It's very much focused on the patient and their health and what they're motivated to do, or if they even realize, or admit or think there may be a problem or not. The good thing about this process is that you can train your staff to provide the service. You can get them the training online to be certified and expert. Health coaches, nursing staff, physicians, of course, licensed addiction counselors. There's a whole list. If someone requests that, I can send that information out. But there is an approved training, and if you get that training, you can bill for that service. So I wouldn't necessarily suggest that you have the screening protocol built in through a technological solution. I think your staff on site can do that. If you really wanted to have the full consultation and the follow-up, you could have a staff sign in and have the patient get connected to someone on an iPad and bring that in. They could visit with a counselor. But really, until that person says, yes, I want a service, your staff can manage that process and bill for that process. The annual screen, I think you can bill that once per year. And then the brief interventions, which would be if that patient maybe wasn't ready or started to talk about it, is coming back in. They can get, I believe it's 4 sessions per year. It might be 5 that you can bill for those brief interventions. So those follow-ups after the person says, yes, there's something going on that I need help with. Otherwise, you would keep asking patients annually. Of course, in the acute care setting, we're asking these questions to every patient that comes through. And in primary care, you would set up a process so you're not irritating a patient who already said no, and they're like, man, I have to answer this every time I come in. It's driving me nuts. Nothing's changed. We build it in, so if it's truly a no, we're not asking again for another year. So through that process, you would need to then identify the patient who needs the service. And if the patient says, yes, I would like to do something, there needs to be an assessment. So to authorize the service and move forward and have the ASAM criteria in place, which is the American Society of Addiction Medicine criteria, there's 6 dimensions that have to be rated and filled out, and an interview that needs to be completed. Then an assessment would need to occur. So a licensed counselor would need to provide this assessment to justify the service. And telehealth assessments, I think, are a great solution for this because you can offer that directly from your setting. Do I think it would be better if the patient could, on their own schedule, sign in from their phone or their computer and get connected to an assessment? Absolutely. We've built that process. It's not sustainable past grant funding because of the telehealth bill, and not just for addiction treatment, but for any service, that it can't be reimbursed when a patient signs in from home. I think that would be a great way to do it, but the individual would need to be in the clinic setting, sitting at a computer in an office in that setting. So through that service, you can have a counselor available, figure out what your structure would be for that. If you had a counselor who even said, I can have slots available, 1 slot per day, 5 days a week, or 2 slots per week, you'd have to kind of figure out what your volume might be and who might be saying yes to that. And maybe you start with 1 assessment slot a week and it's every Friday. There's ways to build that so that you can start referring those patients directly to an assessment and get it done within your setting. If telehealth is that solution, that's great. If there's an agency that could partner with you or someone down the street, that's great as well. And obviously, if you can have staff on site, that's great also. But telehealth can be a great component to build into your clinic without having the staff available full time on site in your clinic. You just need to understand volume and start somewhere and use technology to assist you in that process and create access. A benefit of the patient completing the assessment in your setting is that they're more likely to follow through with it. you're not having to create a bridge to another place they've never been to before, that they're more likely to come to a place they're already comfortable attending and get that assessment completed and feel like, you know, my medical staff that I work with, the nurse and physician, are really supportive of this, and I'm going to go back to the clinic to get my assessment completed. So that can be a valuable process. Psychosocial treatment, of course, following the assessment, there's going to be some recommendations, most likely. If you screen someone and they say, yes, I might need some help, I would say most likely it's going to be at least individual sessions. There's some education classes available at a lot of treatment centers that are valuable. But when they recommend outpatient treatment, either individuals or groups, or that individual who's using substances really needs detox or residential, there might be a need for transportation to a detoxification facility. Now, the good thing about detox facilities and drug and alcohol treatment centers is that it's a as-needed service, and we will figure out a funding mechanism for that, and our block grant dollars can come down to bill for detox services. And patients can go to any of the treatment locations across the state. There's not catchment areas for substance use disorder treatment facilities, and that's a little bit different than mental health centers. So here in Salina, we have a 30-bed co-ed detoxification and residential treatment facility. And we get patients from all over the state. And we've just sent out letters to all of the hospital ED directors and CNOs to just once again let them know we're here, what we provide, and how to refer patients to us. We get referrals from clinics, we get self-referrals, and we also get criminal justice referrals as well. But if the patient needs that service, it's figuring out how to get them connected to it. The great thing our staff in the hospital settings can do is really navigate that system, and we've worked long enough with various treatment centers across the state that they know we're going to provide them the appropriate documentation and the patient will qualify for the service. So we can remove some barriers and move through the process a little bit more quickly. But knowing the resources, I think I have a page here at the end that shows how you can look up resources around the area. So telehealth treatment, like I said, signing in from home would be amazing. With our telehealth groups for Western Kansas under our opioid grant, we actually have people sign in from their home phone or computer, and they do that, I think, for an hour and a half, twice per week is how we have it set up. I think it's an evening, and we were starting a day group. I'm not sure if we started that yet. So that's great because you can have many different people from wherever across the state sign into one group and have enough people to make a treatment group work. If you did it a little bit differently than that, let's say maybe you have people show up at a clinic. So if we had a clinic in Southwest Kansas and a clinic in Northwest Kansas and a clinic in Central Kansas, and throw in the other corners of the state while you're at it, if you had people sign in from 5 different clinics all across the state, and you had 3 people from each clinic sign in, well, you'd have 15 people for the group, and that's an appropriate number of patients in a group. We could provide that service and be efficient with our staff's time. If we start a treatment location in Southwest Kansas and we only have 3 people in the group on a regular basis, that treatment location is not going to stay up and running for very long at all. So I think technology allows us an opportunity to create an additive model of treatment delivery via telehealth to multiple locations and still provide an efficient, effective service with the number of patients we need to keep the group moving forward, and the patients need to have an appropriate number of individuals in their treatment group to really benefit from that group process. So that could be a great solution. If you're in a single clinic and you could get someone to sign in and provide even a basic, you could do a 1-hour group 5 days a week or 1-hour group 2 days a week. Figure out what it looks like. How can you create access to a treatment service? Or, as we mentioned with assessments, you could do some telehealth individuals. It might not be the right service for that individual. However, if you have 0 services available now and you start by offering a few individual sessions, that's great. That's a step in the right direction. So it doesn't mean you're going to have intensive outpatient and outpatient and residential and detox all of a sudden. Can you create a way to engage with those patients through a telehealth individual treatment session, similar to how you might set up the telehealth assessment sessions? So medication-assisted treatment, the common medications you're seeing out there, naltrexone is actually the version of Vivitrol is a version of naltrexone that you inject. Naltrexone is the oral medication. That's actually an opioid antagonist, so it's blocking the mu receptor site for the opiate in the brain. The benefit to Vivitrol, of course, if you get the injection every 28 days, the individual doesn't have to remember or maybe agree to take it every day. If they skip a dose, then it's only as effective as the person taking it each day. Vivitrol, they get the injection. And when they're taking, let's say, an opiate on top of having the Vivitrol injection in their system, it's not going to connect to that mu receptor site in their brain. They're not going to get that effect of the opiate while they're taking Vivitrol. So that's the opiate antagonist. Buprenorphine is a opioid partial agonist, so it is lighting up that receptor site partially. Oftentimes we utilize Suboxone, which does have the buprenorphine plus the naloxone component. That guards against overdose risk, which is a great component to have in that medication. There is also Subutex that does not have the naloxone component. I know our physicians provide that to pregnant women because that naloxone component within Suboxone is not good for the fetus. So we do have some pregnant women who would be on Subutex instead of Suboxone. And I think otherwise they don't utilize Subutex much because, once again, we appreciate having the buprenorphine and naloxone medication via the Suboxone. Methadone is a full opioid agonist. So when an individual is taking methadone, it's actually lighting up that receptor site full force as if they were taking an opiate. So I think methadone kind of gets a bad rap, and it's not really fair. I think in the past, as you might see some methadone clinics, and hopefully you don't see this happen these days, but people might line up and take the medication, and really the perspective on those, and maybe some were operating this way, is that, well, people are just lining up each day to take this drug, and then they're going off and doing whatever, so we're just creating a place for them to use a drug. There is a benefit in meeting the people and trying to engage them further, but maybe there are some places who are just giving medication. That's not going to be effective as you set up a dosing site and give that medication, which is an opiate, because they're not getting those other treatment components, and they're not changing their thoughts and their behaviors and their life outside of, this is where I can go get this. However, they're also not shooting up with needles and spreading disease in other ways by going to the clinic. So I have seen some very good long-term outcomes around methadone clinics. Patients who've been taking methadone for 30 years, and as I mentioned, the physical dependence versus the criteria for addiction, yes, they're physically dependent on methadone. Yes, they would be physically dependent on Suboxone. Might be missing questions on here the whole time I'm talking. I'll keep that open now. So if they're missing those components, I lost my train of thought because I opened my box here. We need to make sure that they're getting the medication they need. If they're physically dependent on those medications, that is okay. Do they meet the criteria for addiction, or are they doing well? They're taking the medication daily, or they're getting, methadone or buprenorphine. Vivitrol wouldn't be the same effect because it's not actually feeding that receptor site. But they don't have this chaos in their life anymore. They're keeping a job. They're taking care of their children. They have valuable relationships. They're productive members of society. And they're physically dependent on this medication, as someone might be with a blood pressure medication, with an antidepressant, with the allergy medication, as I mentioned earlier. So that's okay, and there have been very good research studies done on the effectiveness of these medications. Now, naltrexone, Vivitrol, buprenorphine, and methadone can be used for opioid use disorder. Naltrexone and Vivitrol can be used for alcohol use disorder. I hope over time we have more medications for more substances. And I know there's a lot of research going on around that as you talk about stimulants, amphetamine, cocaine, et cetera, that they're working on medications for those. There aren't any currently approved by the FDA. Individuals who prescribe buprenorphine specifically have to get a waiver. There is a waiver link listed on this brochure that we created down at the bottom. It's asam.org, Education Live Online CME. So that's a free course. Physicians can take an 8-hour online training and be approved after they take the training and submit for their waiver to see 30 patients for a 1-year period. One of the questions that popped up here, are you able to connect with rural EDs, primary care, and mental health clinics in Southeast Kansas? So if the question is if CKF specifically can connect with these facilities, yes, we are able to. Through that Southeast Kansas grant, we're specifically working with, I think, 3 counties to start, and there's 10 counties they're focusing on. But we can work with any facility across the state, and we can assist with the screening process to identify how to build it into your system. We could also assist just to let you know how you refer patients to us. And then we've gone as far as having contracts, of course, with the 2 hospitals we're in. So if there's any specific questions about how we might be able to assist you, and as I say, to our health network up in Central Kansas with our group of hospitals, if anyone wants some help and they want to ask questions and have me look at how you're doing things and how you might improve it or add something in that's not there, just reach out to me and let me know. And if I'm not answering that question correctly, let me know and I will answer it more clearly. So buprenorphine, a physician who gets waivered can see 30 patients for a 1-year period. NPs can also get waivered, NPs and PAs. They take the same 8-hour training as the physician takes, but they also take an additional 16 hours. Once again, it's all facilitated online. So once they take this training, the NP and PA as well can only see 30 patients for a year. Once that 1 year is completed, they can see 100 patients, and after that time, they can apply to see up to 275 patients total. Now, the feedback I get from physicians, and our medical director mentioned not too long ago, he said, man, I can prescribe all these different opiates, but this opiate that's specific to helping patients and it's a partial agonist, I have to get all this special training and I can only see 30 patients for a year. And I agree that it's a little cumbersome. I love the training component. I think everyone needs it. As I mentioned, even it's just for the basic fact that we shouldn't be training people to say, here's a medication and that's all you need. So they need to talk about treatment, psychosocial treatment along with the medication. But that other component of it, that you have to wait a year to see more than 30 patients, man, that's tough. We just hired a full-time NP at our clinic so we can see more patients because we've been kind of piecemealing it with some in-person staff to do the induction and some telehealth staff to do a lot of the maintenance appointments. But we need a full-time NP here. Well, she can only see 30 patients for a year, so we have to deal with that over time and have additional staff in place until that year happens, and then she can see 100, and then we can increase to see more patients up to 275. If you're prescribing Vivitrol and naltrexone, there's not a patient limit. It's not an opiate. As I mentioned, it blocks that site. You can see more patients with that. And also, I think people find that as an effective way as far as cost effectiveness. If a patient comes in and gets started on Vivitrol and gets that shot, they can come in subsequent times every 28 days and get the shot from nursing staff. So that helps as far as physician time and how much money you're putting into that process. But I think it's best to have various treatment options available for patients because it's not a one-size-fits-all. You're not going to start someone who's actively using opiates on Vivitrol. They're going to have to be sober for a period of time because if you put them on Vivitrol immediately while they're using, they're going to go into withdrawal, and that's not a good process for them. And on the other end, if a patient's coming in and they're in detox and they need to taper off from use, you can start them on buprenorphine, which is a good thing because it's just tapering off that process and you can continue on buprenorphine long term. So there's different medications appropriate for the different timing with the patients and their use. And as we go along, hopefully there's more medications available. Oh, so I guess I typed the link at the very top, not just down on the brochure. So if you want to go check out that training, and there's other trainings available online too, not just through ASAM, but this is the one that we've identified for people to utilize. So as I mentioned, telehealth appointments for MAT, something we've done because, as I mentioned, the induction, you cannot do the induction via telehealth. When the patient comes in and they get started on the medication and they start to go through that withdrawal process, and then they begin buprenorphine, which kind of catches them before they bottom out. You're starting them on this partial opioid agonist during that withdrawal process. That requires in-person with a physician. It's not allowed in a different way as far as utilizing telehealth staff or just having a nurse on staff. I know you can have someone who, and I think this essentially takes 2 physicians' time, you can have someone who's not waivered in person with the patient while a waivered provider signs in via telehealth, and you can do induction. Otherwise, we've utilized our telehealth staff to manage those patients' medications as they move along. So when they're in that maintenance phase after induction, we have telehealth staff available to meet with those patients each week. And as the patient goes along, they may have weekly appointments and then every other week and every 3 weeks and once a month. I think we have some patients at this point that are 2 months out on their appointments. So as they're doing well with the buprenorphine and they're taking it appropriately and engaging in treatment, they can go a little bit longer between appointments, but those appointments can be facilitated via telehealth. As I mentioned, Vivitrol, having nursing staff available to administer the shot, you can do that. And of course, you don't need a physician present very often at all. So just some different ideas to utilize staff more efficiently and offer the service via telehealth, because maybe you don't have a provider in your area who's waivered or who wants to see patients for that service, et cetera. You might be able to get someone signed in via telehealth, which we did for quite a while. And now we're trying to just get more hours available in the clinic as we expand the services we offer. So care coordination, of course, is going to be very valuable. We can't just do it one-dimensionally with these patients. We've got to understand what's going on with them and their total care and their whole health. I have some slides at the end that just really focus on 8 dimensions of wellness, whole health. We really want to engage patients to benefit from this service and maximize that effectiveness. If we're just treating one thing and we're blind to all the other pieces of the equation, we're not going to provide the best service we can to these individuals. I am really excited about IRIS. I hope that this keeps moving in a positive direction. You know, maybe, I guess I've primarily seen it with health departments and groups within communities and how that IRIS community works, or if there's 3 counties tied into a community, there can be a really clean referral process that's tracked. I would like to see it, you know, expand to acute care as well. It seems like some acute care settings have an electronic referral process that maybe they purchased and they've already built, as we've run into, and then we get added to that electronic referral system. But IRIS is something that is really being pushed, and I think is a great thing. It seems like KDH&E and KU are really involved in that process. And we've signed on to serve in Southeast Kansas. So when I talk about the screening process happening and then a referral to us to provide telehealth assessment, we would utilize IRIS for that process. So it's a HIPAA compliant, of course, confidential within that process. It's electronic. I kind of view it as mixing a fax machine with an EHR, and we can get that referral in there. We can track how it's going. And if the referral gets picked up and we know that we close that gap, we can monitor that process. Now, in the past, if you're faxing something and you don't know who picked it up, or you don't know if the person actually got scheduled, or if the individual called the agency you connected them to, we're not able to close that gap, and we don't really know what's happening with patient care. So I'm excited about IRIS, and any tool that can pull that together and create more of a streamlined, efficient process is great. Virtual treatment team I mentioned on here, because if you have telehealth staff signing in, make sure they're involved in some way, that it's not just they provide a service and then they're essentially separate from your agency and all your other services. You need to keep them engaged and talk about how the patient's doing and make sure you're all on the same page. If you have, you know, a physician sign in for MAT and you also have a treatment component, and the physician says, well, this patient's not doing things right, I'm going to discharge him, and the patient gets discharged, and you say, wait, we have all this other knowledge and we've been engaging with this patient. Here's someone who sees the patient 3 times a week, and here's a physician who sees him once a month, and we need to pull all that knowledge together and talk about what's best for the patient. We need to all be on the same page, or else it could have negative consequences on the individual we're working with. Phone apps, Chess Mobile is an app we used to use, and we're currently on MyStrength. I would say Chess Mobile has some good things going on it, and there was a heavy focus on drug and alcohol use and addiction, and there were some neat components with that app. However, MyStrength is more of that whole health model, and it's not just about substance use, it's about setting goals for diet, exercise, maybe there's some depression and anxiety and the person's trying to feel a little bit better, and substance use as well, of course. There's just multiple things on MyStrength app that we offer that app to our patients, to our patient families, and to our employees, because it's not just a substance use disorder app. And within that app, there's also evidence-based curriculum. So as we were discussing setting up a treatment modality via telehealth and patients could sign in from home, MyStrength was a cornerstone of that, because the patient could engage in evidence-based curriculum in between sessions, and we could carry that forward in discussion and processing during sessions via telehealth. Now, with the rule that patients have to sign in from a clinic, we'll probably use similar curriculum that we use in person, because people will have to show up to a structured physical space versus having the app. But the app's still a component with all of our treatment programs. When a patient's not in treatment groups, it's the weekend, it's the middle of the night, it's just between sessions during the week, they need something to engage with. They need a support system, And having those people in your life is great. Having an app that you can engage with and, you know, go through some exercises and work on whatever's going on. If you're feeling a little bit anxious, etc., you can go through some practice and some tools that are on the app. So that's been a good thing for us. So if you have the opportunity to use phone apps and close those gaps and provide a resource on a regular basis, 24/7 in the patient's pocket, that's a great way to go. Additional resources, we do have an addiction self-assessment on our website. So you can go to this link at ckfaddictiontreatment.org. It's at the bottom of, I think, all of our substance pages when we talk about different substances of use. We have this at the bottom of the page. So someone can go on it and go through and see, am I at low risk or moderate risk or high risk of having a substance use disorder, and what can I do next, and do I want to reach out to a staff member at CKF? We have that available. We also have a help now. Basically, if someone's sitting in the middle of the night and wants help, and when someone wants help, that window can close pretty quickly. So maybe in the middle of the night, they're saying, you know, I want to do something about this. And the next day that window's shut. We want to have a way for patients to access our services. So they would reach out through our help now. They'd send a message. If it's asking a general question about what we offer, or they're saying, you know, I'm really struggling, here's what's going on. We have a staff who monitors that and would reach back out to the patient. So that's been a good service to have available the last couple of years. Treatment providers, if you do not know what's available in your area, make sure you're getting on the SAMHSA site, and it shows mental health centers and drug and alcohol treatment centers. And some mental health centers do drug and alcohol treatment, so just to keep that in mind. It will show you what services are available where. I hope it's up to date. It'd be great to have a state system that puts it on a map in such a way. But click on this, search by your zip code or by your city or even by the whole state, and you can see what's available if you're not familiar with what's around you. Make yourself familiar, find out what they have available, and reach out to them and ask questions. Recovery support, of course, AA, NA meetings, and even Al-Anon for family members who are struggling through this process of a loved one having an addiction. This is great because meetings are available, man, maybe not everywhere, but it's such a flexible process for someone to be engaged in this positive recovery support. And then if they travel, they can also go to a meeting wherever they travel. So I know people who, you know, they go to meetings in Salina, and if they're in Topeka or wherever, they've already identified where they're going to go that evening for their meeting. That's great. And people don't use it every day forever. And some people like to use it, and there's some people who don't want to use AA and NA. But there's a huge benefit there for the people who do, and the flexibility that's involved with the support. And maybe people who are in long-term recovery go once a week or twice a month or whatever it may be, but there's just a very flexible scheduling and availability options with those meetings. And then preventoverdoseks.org. If you haven't gone to that site, there's some great information there. Along with there was an epidemiologist at the state who put together a lot of data around prescriptions, opioid prescriptions, benzo prescriptions. If you go to preventoverdoseks.org, you can access that data. And I've been told as of yesterday, someone let me know that they've hired a new person for that position. So hopefully that information that I think ended in 2017 and the data you'll find there extends beyond very soon. And also, if you just don't know what prevention looks like in the state currently, because funding and structure changed a lot from the past, there's not the regional prevention centers we used to have. There are staff assigned to your region of the state. So if you go to preventoverdoseks.org, you'll find that staff member who's assigned to your region of the state. You can reach out to them and ask questions and try to figure out what prevention can look like in your community. So that's a great site to go to. Just to put up the map, CKF has covered the 65 counties for the last 2 years under the opioid grant. The next round of funding is called the SOR, State Opioid Response. The old one was called State Targeted Response. So the name's changed a little bit, but it's the same service, and we'll be applying for those 65 counties again. There's probably going to be other people applying. So as that gets decided and this map changes, make sure you know who's providing the services in your part of the state. If you're not within a CKF catchment area, that's okay. Contact KU, 4 County Mental Health, or Heartland RADAC at these numbers listed, or email addresses, to ask what their services look like under the grant, and they would be happy to assist you. And once again, I just have to consider and mention at the end of my slides, patient outcomes. People are dynamic individuals. What can we do to best treat them? Remember social determinants of health. One of the biggest ones is social isolation. If someone's socially isolated, that can have the largest negative effect on their health. And when we talk about access or signing in on an app or into a treatment program from home, that would be a great way to decrease that social isolation. However, what are ways you can start that process and engage them more and more with social connectedness and support. But as it mentions here, there's other components to look at. We need to consider all of those components. And then also I mentioned a few times the 8 dimensions of wellness. So we keep this in mind as we work with patients, and also as patients come to our recovery center, they're working with peer mentors as well as their counselor. And we're making sure we're talking about all of these components, because it's not just that someone stops using a substance and everything's better. There's many different areas they need to work on, just like all of us have many different areas that we want to keep growing and working on. That being said, there's my references from this presentation, and any questions? All right. Well, if there's no questions, I will probably turn it back over to Janine if she has any wrap-up items.
I do. Thank you.
Thank you.
Thanks so much, Shane. What a great presentation, and we really appreciate your expertise in this area. And folks, please don't hesitate to reach out to Shane, because he is a wonderful resource and can answer those questions that you may have that you just can't think of right now. So please, there might be something in the chat. Great presentation. Thanks so much from Northwest Kansas. So just lots of gratitude, Shane, for your great presentation and your expertise. Thank you so much. This has been a presentation of the Heartland Telehealth Resource Center. Our next webinar is June 4th, and it's entitled Telemedicine, a Provider Perspective, and it will be given by Terry Wagner of Ellsworth County Medical Center. They've got a great telemedicine program going, and she's going to share with you what it takes to get one like hers going. And also, the National Consortium of Telehealth Resource Centers has a webinar coming up May 16th entitled Distance Counseling, Best Practices in Higher Education. And this webinar is actually sponsored by the HTRC, and our speakers are going to be from the University of Kansas Medical Center, Dr. Alessandria and Dr. Long. So if you want to register for that, it's May 16th, please go to telehealthresourcecenter.org, and they will be talking about behavioral health and higher education. Thank you again. If you have any questions, please do not hesitate to reach out to the HTRC. This concludes our webinar, and we look forward to seeing you virtually next time. Have a great day.